All right. Thank you all for joining us for our Ask the Expert series. This is Gina Parzial. I'm the Executive Director for the Alport Syndrome Foundation, and I am very thrilled to introduce Dr. Bruce Morgenstern. He is the Associate Dean of Clinical Affairs for Roseman University College of Medicine in Las Vegas, Nevada, and he is going to be helping everyone today understand all of the numbers and tests and information that doctors may be providing that may be a little bit confusing when it comes to Alport syndrome. We are very grateful to him for donating his time to present this information to us today, as well as to Global Genes and Reata Pharmaceuticals for their donation to make this series possible. Without further ado, I'm going to turn this over to Dr. Bruce Morgenstern.
Thank you very much, Gina. I'd like to start this by thanking the Alport Syndrome Foundation for giving me this opportunity, and then, of course, by doing exactly the wrong thing, and that's apologizing for the nature of this presentation. I've spent a really long time learning how to help people learn things, and really webinar technology is not the most ideal way to do it, but we'll do what we can. It's difficult for me because I'm just looking at my computer screen, so I have no idea if anyone's paying attention. And it's difficult for you because you'll have to read slides and listen along with me. And what I've done just to try to make that easier is I've made the slides intentionally far wordier than they ought to be if you were doing this in an auditorium or another kind of a setting. But the goal today is to try to help everybody make sense when your doctor gives you lab results, or you log in if you have a patient portal and you look at your own lab results and you see things that have asterisks or numbers and you want to know what they mean. The goal here is to try to help you get a framework to understand what some of those numbers mean. And by way of full disclosure, I do need to tell you that I'm on the Speakers Bureau of Alexion Pharmaceuticals. That's really not going to be remotely relevant for what we're talking about today. And I am a dyed-in-the-wool pediatrician and pediatric nephrologist. So every now and again, my focus and my need to sort of point out where children differ will come through in the course of this presentation. To make things very simple, when we think about the kidneys, we're really talking about two things that happen together and in an interrelated fashion. And one is that the kidney is comprised of a crude, pressure-driven filter whose main job is to filter stuff out of the bloodstream, and then this remarkable fine-tuning mechanism whose job is to make sure that all the bad stuff comes out in the urine and a lot of the good stuff gets pulled back into the bloodstream so that the balance can be maintained in a very appropriate way. It's remarkable how that happens, but it continues to happen, and we'll talk a little bit more about that as we go on. So the filter is the glomerulus. We'll look at this in some cartoons in just a moment, and its job is to just crudely filter the blood. So when blood is filtered through this thing called the glomerulus, and there's lots of them in the kidneys, then all sorts of bad things that are in the blood come out through that filter. A lot of good things do too. It's not a very fine filter. It's a very crude filter. So a lot of things that are important to us also make it through that filter. So it's the job of the other parts of the kidney, and I'm going to broadly refer to it as the tubular interstitium. It's the job of those other parts of the kidney to maintain all the balances, to keep all the minerals, the electrolytes, things you've probably heard about like sodium, potassium, and calcium and phosphorus. That has to be maintained in balance by the other part of the kidney, not the filter, but the tubular interstitium. And that part also maintains the balance of the acid levels in your bloodstream. It all works together to maintain your blood pressure. It activates vitamin D, which is important for your bone health. And as we'll discuss in just a little bit, it also helps maintain your red blood cell volume. So the kidney got blessed with a whole bunch of different functions over time. Our kidneys work very differently, for example, than fish and birds, but not all that differently from other mammals. As a reminder for people who need a little bit of basic anatomy, we should have two kidneys, one on the left and one on the right. The kidneys get their blood from the main artery in the body called the aorta, so blood flows into the kidney through the renal artery. It gets filtered by the kidney, and then the blood flows out through the renal vein. And the urine that's formed goes down these tubes called the ureter, gets stored in the bladder, and that's the stuff that, when we urinate, actually comes out. If you broaden the view a little bit or actually zoom in to the kidney, what you can see is that there's an outer part of the kidney called the cortex. There's an inner part of the kidney called the medulla. We're not going to talk a whole lot more about that. And then there's the one thing in the kidney, this fleshy part in the middle, that actually probably has the most logical name of just about anything in the human body, because most of us refer to this area as the collecting system. And this is the area where urine is collected from all the different parts of the kidney before it flows down the ureter into the bladder. The kidney, how did we do this? The kidney is made up of a bunch of these little filtering units that are called nephrons, and they consist of a filtering unit. We'll talk about this just a little bit more. The glomerulus I've talked about briefly, and then all this fine-tuning mechanism that's part of the tubular interstitium. And you can see that these nephrons start out in the outer part of the kidney in the cortex, but they have bits and pieces that go deep into the kidney or into the medulla. And you can see that at the end of this whole long process, the final stuff, that is the real urine, actually comes down to the very middle towards the collecting system. The nephron's a pretty complicated kind of a thing. This is another cartoon of a nephron. In the middle, this tiny thing, hopefully you can see my pointer, this tiny thing is the glomerulus. The red and then the blue are the blood vessels that are necessary, and this relationship between the blood vessels and all the parts of the nephron segments are critical for the way this whole thing works. And so you can see the little white, that's the tubules, and all the blood vessels, that's all part of this nephron. And as I said, there are 1 million of these in the kidneys. This is just sort of spreading it out and showing you that because we as nephrologists like to name things, we've got things with names like Bowman's capsule and proximal tubule and distal tubule and collecting duct. None of that really is going to matter today. So what does the nephron do? Well, the nephron is the whole thing. Remember, it's the filter, the glomerulus, and the fine-tuning mechanism. So if we start with the filter, just the glomerulus, one of the things it does is it filters water. And it actually filters about 180 liters or 47, almost 48 gallons of crude filtrate every day. We only make about 1.7 liters, about half a gallon of urine. So you can see that well over 99% of the water we filter gets reclaimed or reabsorbed back into the body. And that's crucial. That's part of that important fine-tuning mechanism. But there's a ton of filtering that happens. This 180 liters a day is what all of the glomeruli, each of the maybe 2 million glomeruli, 1 million in each kidney, crudely filter every day. And of that 180 liters, a lot of work has to happen in the fine-tuning mechanism. So the fine-tuning mechanism and the work of that is reflected in part in this table. It's a little bit lower. You see this on the right where it says components. Urea is important. It's one of the nitrogen waste products, and there's not very much in the plasma, and all of it comes into the early filtrate. And you can see that anything that's small that's in the plasma shows up filtered by the glomerulus in exactly the same amount because it's a crude filter. Where the filter really starts to work more like a sieve in some ways is when you get to proteins, which are huge. And these proteins are basically not filtered at all. So if it's not filtered, it's unlikely that there's going to be protein in the urine. When there is protein in the urine, as we'll get to in a little bit later, that's not a good thing. But when you can see what shows up in the urine compared to what's in the blood for some of these things, like urea, which is something we want to get rid of, or uric acid, which is also something we want to get rid of, there's a lot of concentration in the urine, but still a bunch of it gets reabsorbed back into the body. It's not the most efficient thing to reabsorb things you want to get rid of, but these processes are important, and they do have an impact on the blood tests. Sugar, glucose is something we actually don't want to get rid of. It's not normal for there to be sugar in the urine, but it's a very small molecule and it gets freely filtered at the glomerulus, and so it starts out in the very early urine, there's sugar, but all of it gets reabsorbed or reclaimed by the kidney. When we think about how much gets filtered, though, this 180 liters, that's a number we're going to come back to in a little bit. There's a lot of filtering that takes place. So the glomerulus is the filter, and it's a pretty cool kind of a thing, actually. This is an artist drawing a diagram of the kidney, of a glomerulus, and you can see blood vessels here. These are tiny blood vessels where blood flows in and blood flows out, and this is a sphere. I use this cartoon because you can really get a picture of the 3 dimensions here. And the little blood vessels fold themselves up into this sphere, and by having all these tiny blood vessels, there's a lot of surface that's available for the filtering to happen. And all this other stuff is the tubulointerstitium, and you can see why it's called tubules. It's surrounded by a bunch of tubules. And this little space right here at the far end of the glomerulus is where the early urine starts. So that's where some of that 180 liters of urine at 46 gallons of urine starts to flow, but does not show up in the final urine. This is an electron micrograph of a normal glomerulus. And so this is what it looks like. If you can magnify it many, many times, this is compared to the diagram I showed before. It looks roughly the same, but doesn't have all the nice colors attached with it. And this is the outside of the glomerulus. The inside of the glomerulus, if you slice through it, would look a little bit more like this. This, of course, is still a cartoon, but you can see the blood would flow in this way. It would go through all these blood vessels in here and then would flow back out that way. And what you can see down here around 7 o'clock is just a slice through one loop of a capillary. And on this diagram, you can see a black line that is meant to reflect the basement membrane of this capillary. Why does that matter? Well, because this is a conversation about Alport syndrome, and if you were to look on a kidney biopsy of what a normal glomerulus would look like, that basement membrane is this pretty boring-looking, bland, but relatively thick gray basement membrane. And in somebody who's got Alport syndrome, what you can see here is a very, very thinned basement membrane, and it doesn't have the same boring gray color, and it doesn't have the same thickness. And that's the hallmark of the Alport syndrome. It's an abnormality in the collagen that forms these basement membranes. So we as nephrologists spend a lot of time trying to confuse medical students. We try to confuse medical residents. We try to make people think we're really smart, and one of the ways we do that is by using really different terms sometimes to say the same thing. So you'll hear us talk about kidneys. You'll hear us talk using the word renal and nephrologic or nephrological. So I'm a nephrologist. I'm a doctor who takes care of kidneys. And then we use things like disease, insufficiency, and failure. The National Kidney Foundation has really told us we should simplify this, and they're right. So most of us now talk about kidney disease. We'll say we're kidney doctors, and if the kidney disease is something that's not going to go away, we just add the term chronic kidney disease to this term. So we're trying to make it a little bit easier. So now to get really to the point of what we're talking about, which are the common tests that doctors order. The 3 most common tests that doctors will order for just about anybody, much less anybody who's got Alport syndrome or a family member with Alport syndrome, include a blood count, which we often refer to as a CBC, and then there are chemistries. There are many, many synonyms for the tests that are chemistries are included because they're often ordered as panels, and they have different names as panels, and they include 6 tests, 12 tests, 21 tests, etc., but they're generally considered chemistries. And then finally, there's the urinalysis. The pediatrician in me feels obligated to tell you that levels can vary based on age and sex and size. So all of these things matter. The labs, when they do these analyses, will have a rough idea of your age, because one of the identifiers that's used to know that you are you when the test is being performed is typically your date of birth, and they usually know your sex, but they don't know your size necessarily. And we'll talk about in a minute why that really matters. So we're going to take these one at a time and talk a little bit about them. The CBC, the complete blood count, is called a count because included in that is a count of the red blood cells the white blood cells, and the platelets. So those are literally, in an automated way, are counted. So that's how this test got to have the name of a complete blood count. In the old days, they were manually counted, but now, of course, this is all done automatically. Importantly, when you think about the kidneys, the CBC also reports hemoglobin and hematocrit, and I'm going to come back to those in a minute. And then there's a whole series of other indices that have to do with the sizes of the red blood cells and the platelets, and those have implications. I don't mean to belittle them or pay no attention to them, but the things that matter for patients who are worried about kidney disease include the hemoglobin, the red cell count, the hemoglobin, and the hematocrit. Hemoglobin, if you haven't really thought about it in a while, is an iron-containing protein that's inside of your red blood cells, and its main job is to carry oxygen around to your body. So we all like to have a decent amount of hemoglobin because it means that our body is getting a sufficient amount of oxygen. If we lack a lot of hemoglobin, we have what's called anemia. I'll come back to that in a minute. Additionally, there's another test that's in ways related to the hemoglobin, and that's the hematocrit, but it's really a percentage. When we talk about the hematocrit, if we think about blood, blood has predominantly red blood cells and this liquid around those red blood cells, which is called the plasma. If you put that into a centrifuge and spun it for a while, all the red cells and the white cells and the platelets would go to one end of the tube when you put it in a centrifuge, and all the plasma would be separated, and you could see what percentage of the blood really is made of the red blood cells. And that number, just by happenstance, frequently is about 3 times the hemoglobin. So a normal person would have a hemoglobin of about 13 or 14 and a hematocrit 3 times that, or about 40 to 45. But this is a percent, and this is a number in grams. So they have very different meanings, but they're often reported side by side. And it turns out that the kidneys make a hormone. The kidneys make this stuff called erythropoietin, which I had to look up how to spell because as a kidney doctor I refer to it mostly as EPO. EPO is a hormone made by the kidneys that actually tells your bone marrow to make red blood cells. So if you have advancing kidney disease, you make less EPO. If you have less EPO, you're going to make fewer red blood cells, and you're going to have a lower hemoglobin, and you're also going to have a lower hematocrit, so you're going to have anemia. I should point out that the commonest causes of anemia really do not include kidney disease. The commonest cause of anemia is iron deficiency, which is not a complication of kidney disease. You can have iron deficiency and have kidney disease, but kidney disease does not cause iron deficiency. However, you get the idea of whether or not somebody is likely to have iron deficiency or some other nutritional deficiencies based not only on the red cell count, the hemoglobin, and the hematocrit, but some of those other indices I talked about before. When you don't make EPO, those indices tend to be somewhat normal. You do make red cells, you just don't make enough, and their size is relatively normal. So the CBC is one indication that you might have some evidence of kidney disease, but it's actually not an early finding. You have to have pretty reduced kidney function before you make less EPO and have anemia. Chemistries are really sort of where the thing is, where the most important information comes from. And so we're going to talk about this in a few slides. So we talk about the tests that are done, the common kidney-related tests that are done. The first one and the most important one is the creatinine. Creatinine is something that is a muscle breakdown product. We all have muscle, and our body has a normal process for muscle to age and turn itself over. And so we have muscle breakdown and turnover every day. And every day, as a consequence, we make creatinine. And we all make it at a pretty consistent rate. We don't do anything with it. Creatinine's not good for us. It's not bad for us. It just comes from the turnover of muscle. But it's freely filtered by the glomerulus. So it just goes, it's a small molecule, it zips through the glomerulus, and the fine-tuning mechanism could care less about creatinine for the most part. So the amount of creatinine that gets filtered by your glomeruli is what shows up in your urine. So it's the most important marker for whether or not you have evidence of kidney disease. However, it comes from your muscles, so it really sort of matters in terms of size and gender, et cetera, and we'll come back to that in a minute. There's another test that a lot of people talk about called the BUN, or the blood urea nitrogen. It's really a legacy test, and personally I think it's just kept on these chemistry panels to annoy nephrologists. Many, many years ago, it was the best way we had to measure kidney disease. And urea, as I talked about a little bit ago, is one of the major waste products that your kidneys need to filter. But it turns out there are a lot of things that contribute to your level of BUN, and it can fluctuate a lot more than your creatinine can. So it's just not as good a marker of kidneys in routine blood tests. I do have to point out that for kidney doctors, when patients are on dialysis, the BUN is an important test because dialysis measurements are largely based on the BUN. But for routine patients not on dialysis, it's really not the most helpful test. Most of us have heard of albumin. It's a specific kind of protein. It's a really big protein. It's one of the proteins that is not filtered at the glomerulus. So the kidney really doesn't have to do very much with it. It doesn't get filtered to the glomerulus. It doesn't have to be reabsorbed or reclaimed by the tubular interstitium. It's just part of the blood that flows into the kidney and flows out of the kidney. It's not supposed to be in the urine because it's not supposed to leak out the glomerulus. Sodium, potassium, important minerals. Sodium is in the plasma. It's in the fluid that bathes the red blood cells, but remarkably not nearly as much of it is inside the cells. Potassium, on the other hand, is present in small amounts in the plasma, but it's present in much larger amounts inside of our cells. And part of sort of what keeps us alive is our cells' ability to keep potassium in and sodium out. This CO2 people refer to as carbon dioxide. You may remember if you took chemistry, that CO2 is the chemical abbreviation for carbon dioxide. It's really a reflection of how much acid is in the bloodstream. If there's a lot of acid in the bloodstream, the CO2 level will fall. If there's not a lot of acid in the bloodstream, the CO2 level will be normal or can even be somewhat high. Calcium and phosphorus obviously are minerals that are critical to bone health, and the kidney is very intimately involved, particularly a lot of the tubular interstitium, in maintaining the calcium and phosphorus. And it's way too much to talk about for this webinar. So if your kidneys are not working, particularly if they're not working well, then usually the filter is not working. It's possible for the filter to be normal and the fine-tuning mechanism to not work very well, but for the purposes of discussion, particularly as it relates to Alport syndrome, really, if the kidneys are not working well, it's a problem with the filtering at the glomerulus and also, to some degree, usually some of the fine-tuning. But if things are not getting filtered at the level of the glomerulus very well, then the things that should be filtered there go up. So your creatinine, the BUN, the phosphorus, the potassium in your bloodstream will rise. Sodium can go all sorts of ways, and go up and go down and can stay the same. It's not a really good marker of whether your kidneys are happy or working well or not. Typically, the glomerulus and the tubular interstitium work together to balance the acid level in the bloodstream, but if the filter is not working, if your kidneys are not working well, you tend to have more acid in your bloodstream and therefore the CO2 level falls. And if part of the issue with the glomerulus when they're damaged and not working is they also get leakier, then things that shouldn't leak out of the kidneys do. So if there's a lot of albumin that's normally not getting through the filter that does, the albumin level in your blood may fall as well. And then we're going to talk about the urine. The urine is something that has been tested for years. Fortunately now, kidney doctors don't need to taste the urine, but many, many years ago, hundreds of years ago, that was something that doctors did, and it was in fact how diabetes mellitus got its name, because diabetes is Greek for large volumes of urine, and mellitus is Greek for sweet. Fortunately, we don't have to taste the urine anymore. Most urinalysis testing is done by what's called a dipstick, which is precisely what it sounds like. It's very similar to what you have in your car to determine whether or not you have enough oil. In the urinalysis, the dipstick often has 10 separate tests on little squares that are impregnated on that dipstick, and they each have a little reaction that takes place over the course of up to 2 minutes. And the commonest 10 tests that are tested for on a urinalysis is to look for blood, for protein, to look at the specific gravity, which is a measure of whether your urine is concentrated or diluted, to look at the pH, which is a measure of how much acid is in the urine, and then if you're worried about infection, to look at white blood cells in the urine and this stuff called nitrites in the urine. And then there are tests that just have hung on for years and years, but really kidney doctors don't use them very often, and really nor do the other doctors for whose areas these tests may reside. So the urine tests still look at glucose and ketones. Diabetologists who manage patients with diabetes no longer worry about the glucose and ketones in the urine. They are useful in some other conditions, but really their use for the management of diabetes, which is why they were included on urine tests many years ago, has fallen by the wayside. Additionally, when you talk about chemistries, there are a number of liver-related tests that show up in the blood chemistries, and so the bilirubin and urobilinogen tests that still linger on urine testing really are not that helpful for most of us. So as I said before, the glomerulus shouldn't let protein through that filter, and really there shouldn't be any blood coming through the glomerulus either. So if there's evidence of blood or protein in the urine, that's not normal. And in fact, protein, if it's really there and if it persists, is actually a much worse finding than having blood in the urine. One of the hallmarks of Alport syndrome is you get blood in the urine very early on, and that's a marker of the abnormal membrane that I talked about earlier, but it's really not the thing that's associated with the progression of kidney diseases. And there are many kidney diseases that progress very slowly, and some things that we have trouble calling kidney diseases that never progress, but they're associated with blood in the urine. On the other hand, protein in the urine is really a marker that there's damage, usually to the filtering unit, usually to the glomerulus, and that's most of the time that's a bad thing. However, once again, the pediatrician in me has to remind us that young people, usually from the age of maybe 10 to about 30 years, actually can have some protein in their urine that's just related to their posture. So for many people, there is this phenomenon of what's called postural proteinuria. When we like to confuse people in medicine, we'll call it orthostatic proteinuria. But in this case, there is no protein in the urine when you're recumbent, when you're laying down, but there is protein in the urine when you're upright. The simplest thing that we do in the pediatric world, and many of my internist colleagues do the same thing, is they simply measure a urinalysis on the first morning sample before you've had a chance to be upright and walking around. And under those circumstances, if you have postural proteinuria, there shouldn't be any protein in the urine. There might well be later in the day, but there should not be in the morning. If there's protein in the urine on a first morning sample, that's of concern. And of course, because we've gotten better at the way we do tests, and because the most common protein that shows up in the urine is albumin, we actually now have the ability to distinguish what's called microalbuminuria from macroalbuminuria. And this just relates to the sensitivity of the test. So the protein test on the dipstick that I referred to a little bit ago is not very sensitive. It actually takes a lot of protein and a lot of albumin to trigger that reaction, so that you can see the test on the dipstick. There are also now dipsticks that can measure microalbuminuria, so they detect far smaller amounts of albumin in the urine, and that's important for early signs of kidney disease. It's a very early marker, for example, of the progression of diabetic kidney disease, to actually have micro amounts of albumin in the urine, or what we refer to as microalbuminuria. The picture is only here to remind me that I'm switching gears for just a minute to talk about blood pressure, because blood pressure as a sign that you may or may not have kidney disease is a critical thing. Of course, blood pressure is age and gender and size related, and so it's important to check the blood pressure correctly, but the kidney is critical to maintaining your blood pressure, and the kidney can also be a victim of your blood pressure. So the glomerulus, which is filtering your blood, is a filter that's really driven by your blood pressure. And if your glomerulus thinks it's not happy, if your glomerulus doesn't think it's getting enough pressure to filter your blood, it actually can tell the kidneys to release a hormone that will raise your blood pressure. And this can be problematic because there are circumstances where only parts of a kidney, or one kidney as opposed to both, feel like they're not getting enough blood or enough blood pressure, and the kidney, that affected part of the kidney or that entire kidney, can drive your blood pressure in your entire body to very dangerous levels. And those very high blood pressures actually, in turn, can be bad for your kidneys. And certainly, if you have kidney disease, having high blood pressure has been shown time and time again to accelerate the progression of your kidney disease. So it's very important to remember that if you have kidney disease, you really need to monitor your blood pressure. And if you have kidney disease, controlling your blood pressure so that it's in the normal range is a critical step to delay progression of kidney disease. So then the good news here is we're nearing the end, and we're going to sort of switch gears back to the glomerular filtration rate, because that is the way kidney doctors and other physicians look at kidney disease. And the glomerular filtration rate, the official definition is the amount of blood, the number of millimeters of blood that are filtered by all the glomeruli each minute. And we adjust it to body surface area because we'd like to be able to compare a healthy 5-year-old or even a 5-year-old who might have kidney disease with a slender 62-year-old woman with the offensive lineman for the starting offensive lineman for a National Football League team. Those people all have different sizes, and we should be able to compare them in some way. So let's go back when we talked a little bit. I showed you earlier a table that said that there are about 180 liters of water that are filtered by the glomeruli every day. So 180 liters is 180,000 milliliters, and that's filtered in 24 hours or 1,440 minutes. So a normal adult has a GFR, glomerular filtration rate, of about 125 milliliters every minute, and we usually correct that to a body surface area of 1.73 meters squared. That's an interesting number. Again, we can talk about it for hours. Most healthy adults nowadays are actually bigger than 1.73 meters squared, so it's an odd correction, but again, it's something that's been around for many years, and so we continue to correct to everyone up or down to an average body surface area of 1.73 meters squared. If you want to do it the formal way, it actually requires remembering ratios, and most of us don't. But 125 milliliters a minute is about 4 ounces of blood every minute that gets filtered. Your kidneys get about 20 ounces of blood, or about 600 milliliters of blood flowing through the kidneys every minute. So about 1/5 of the blood that flows through the kidney every minute is completely filtered, but that's still a pretty impressive number, and that number goes continuously 24 hours a day, 7 days a week. It fluctuates a little bit based on what you've eaten and based on whether or not you're hydrated or dehydrated, but that's a pretty consistent number. And if you think about it in another way, a typical adult has about 5 liters or 5,000 milliliters of blood. So all of the blood is completely filtered by the kidneys about every 40 minutes. In fact, if you subtract for the hematocrit, it's even faster than that. So your blood is completely filtered multiple times a day. So it's a very hard-working system in an effort to keep all the bad stuff out of your blood and have it show up in your urine. It actually turns out, fortunately, that it's actually easy to estimate the GFR, the glomerular filtration rate, because as I said earlier, that blood test, the creatinine, is something that's easily filtered by your glomeruli, but the tubular interstitium doesn't care about it. So the creatinine gets filtered by your kidneys, by your glomeruli, shows up in the urine, and it turns out to be a really good marker of the filtering function of the GFR of your kidney. So basically what happens nowadays is we get blood tests that are sent to a lab. The lab measures the creatinine, and then the lab plugs it into a formula. The formulas are based, depending on which formula, are based mostly on your age. Some are based on your gender, and they also actually have an ethnic difference. So in some cases you may see a result that will say the GFR is X, or it's Y if the patient is African American. If you're a pediatrician, none of those estimating numbers work really well. There's a completely different set of numbers that you can use to estimate GFR in children. And again, it has to do with the fact that creatinine comes from your muscles. And it's pretty obvious to understand why a 5-year-old is going to have a different muscle mass than the starting offensive lineman for a National Football League team. So you need to have a different estimating formula. Once you get an estimate of the GFR, you can look at the number that's estimated in milliliters per minute, and lower numbers mean less filtering. Lower numbers signal evidence of kidney disease. So we're going to end up talking a little bit about how GFR gets translated to kidney disease. The National Kidney Foundation years ago sort of tried to simplify this process and then made it a little bit more complex. In this table, we're going to focus mostly on this column, because if we're talking about somebody with Alport or a family history of Alport and some concern, particularly if you have Alport, then that collagen in your basement membrane is not normal. So therefore, almost by definition, you have some evidence of kidney damage. But if your GFR is normal, if it's greater than 90, then you're considered to have chronic kidney disease stage 1. And again, you can see here it's milliliters per minute, and then that weird body surface area correction of 1.73 meters squared. If your estimated GFR is between 60 and 89, that's CKD stage 2. Interestingly, whether or not you have high blood pressure, but high blood pressure still matters. And then you can see if your GFR is between 30 and 59, it's CKD stage 3. If it's 15 to 29, it's CKD stage 4. And if your GFR is less than 15 milliliters per minute, then you have CKD stage 5. This cartoon, oops, I clicked the wrong place. This cartoon is actually a reasonable way to look at this. Again, if your GFR is greater than 90, but we know you have some evidence of kidney damage, you don't have a totally happy and healthy looking kidney, still a little bit damaged, but it's working pretty well. If your GFR is 60 to 90, you have evidence of CKD stage 2, and we, your providers, should be able to come up with some estimate of how quickly things are deteriorating. Certainly we can clearly do that if your GFR is between 30 and 59, then you've got CKD stage 3, and by that point your doctors should be thinking about the possible complications. It's in this level that you start to see things like not enough EPO and anemia as an example. And then as your GFR drops even further, your kidney is looking pretty tired, and your doctors, by this point, you should be seeing a kidney doctor, and then you should be being prepared for, again, we use renal here, and we should use kidney replacement therapy. And as your kidney function gets even worse, we need to talk about things like dialysis or transplantation. So at that point now, we've sort of zipped through this. I wanted to get done in a little under 40 minutes. I stuck to my schedule, so we actually have a little bit of time for questions now.
Yes, thank you. And I'm going to, on behalf of everyone, I'm sure, share the sentiment of ew when you mentioned that doctors used to taste the urine to test it for kidney disease. I'm sure nephrologists everywhere were pretty happy when they came up with a test that that eliminated the need to do that.
Yeah, I think it turns out that doctors as a group are always an arrogant bunch, and actually I think they hired urine tasters. I don't think the doctors, frankly, ever did it. But I'm with you with the ew.
Urine taster. There's a job description. All right, so we can now take questions. I'm going to first encourage people to type in questions online if you have online access, and I will read them aloud for the doctor. And then I'm going to unmute the lines, and people can ask questions that way. And we have a hand raised. So let me unmute the person who asked. You know what, I'll unmute the line so that everyone can do. If everyone can just please remember that we are unmuted, so to please either put your phone on mute if you're not going to speak or not have other conversations.
The conference has been unmuted.
All right, we had someone raise their hand. Sarah, if you'd like to ask.
Hi. I was just wondering how important it would be to find out the GFR for a 6-year-old female that is on an ACE inhibitor because of microalbumin. And I'm just wondering if I've never been given that number, and I don't know if there's a reason for that. Is she too young? I don't know.
Oh no. As a pediatric kidney specialist, I can tell you I look at the GFR of infants. So there's no such thing as too young because it is the marker. It's the way we determine kidney disease or not and the stage of kidney disease. I'm going to guess nobody told you because it's probably normal and they haven't mentioned it because it's probably normal, but it's absolutely appropriate to want to know what that number is. ACE inhibitors, one of the magical things about the whole class of drugs called ACE inhibitors is that they actually serve to protect your kidneys a little bit, but they also drop your GFR just a bit. And you can sometimes see somebody who has low-ish levels of CKD stage 1 drop to CKD stage 2. That's not necessarily a bad thing because as your kidneys are being protected by the ACE inhibitors, they may stay at CKD stage 2 for years and years as opposed to progressing because the ACE inhibitors both control the blood pressure and maybe limited that microalbumin you were talking about, and just in general through some magical things that ACE inhibitors do prevented the progression of kidney disease.
Thank you.
Doctor, how often do you check for GFR in your pediatric patients?
Well, it all depends why you see them, and if you're a general pediatrician taking care of healthy people, the answer is virtually never, because we just don't like sticking needles in children and drawing blood unless we have a reason to do it. So there's a whole subset of children who've had personal medical problems or who are in extended family histories where there are lots of kidney problems, and those patients probably should have blood tests done and should specifically have a creatinine measured so you can estimate the glomerular, the GFR, the glomerular filtration rate. The other subset of those patients I personally think should have a creatinine measured at some point early in their childhood. I forgot to mention this a little bit earlier, are patients who were born prematurely at least before 33 weeks. It turns out that you make these glomeruli when you're hanging out inside your mother's uterus through about 33 weeks of a 40-week pregnancy. So there are now lots and lots of babies who are born earlier than that, who are born at 28 weeks of pregnancy or 29 weeks of pregnancy. Their glomeruli formation are probably decreased. And so they may develop chronic kidney disease because they don't have as many of those filtering units. And to me, those patients should be looked at as well.
We have a couple of questions from online. Why do adult nephrologists do a 24-hour urine test, but pediatric nephrologists do not?
Yeah, I think adult nephrologists just like to torture their patients. And I realize I'm being glib, but the reality is it's really, really difficult to do 24-hour urine collections. Patients at home might be better than nurses who try really hard in the hospital, but at the end of the day, it turns out that humans are human. And so if you're going to do a 24-hour urine collection, you really have to do it properly, and most people don't. So they forget to discard the very first sample. Let's say you start the collection in the morning. When you get up in the morning, that first void that you have should go in the toilet and be flushed away, because that was urine you made overnight. So you flush the first sample, and then you collect everything after that. But if you've got a life, you may be out at work or whatever and have to urinate but not have the container with you. You may somehow miss a sample. You may flush a sample inadvertently. There's a whole bunch of reasons that 24-hour collections are really difficult to do. So many, even of my adult colleagues, have moved away from 24-hour urines. The real answer to that question, though, in terms of the normals, the not normals, is that when you look at what's an abnormal amount of microalbumin in the urine or an abnormal amount of protein in the urine, many of them years and years ago were predicated on complete 24-hour collections. But it turns out there are excellent ways to estimate from a first morning sample to a 24-hour sample.
Great. We have another question from online. How much creatinine change is normal from one test to another?
So for anybody who's listening or will look at this later and listen to the audio as it's recorded, I apologize now. I'm going to refer to the units for tests that we use in the United States. The vast majority of the rest of the world uses SI units, and the number's a little bit different. But serum creatinine levels are usually somewhere around, for normal people, 1 milligram per deciliter. So it's 1 milligram of creatinine, which is a very small amount, in 100 milliliters of blood. And the machines are accurate to 0.1 or 0.2 milligrams per deciliter. And you can fluctuate that much and still be normal. You might even be able to fluctuate as much as 0.3, but if you fluctuate much more than 0.3, that would be really worrisome. And it also depends, again, on your size and your age and your gender. So if you're a professional football player, particularly a lineman, it's probable that your normal creatinine level is not 1.0. It's probably 1.8. And if you came back in and had some blood tests and were still a behemoth and your creatinine was 1.0, I'd worry about the lab. If it was 1.7 or 1.9, I wouldn't get very excited about that. On the other hand, if you're a child and your normal creatinine is 0.3 and it comes back 0.5 the next time, that gets really difficult to interpret because that could be normal fluctuation or that could be an enormous change. That represents a 40% fluctuation. So it's hard to know because of the narrow range that the test can vary for a child, but for an adult, if you fluctuate up 0.1 or 0.2, that usually doesn't bother me very much. If there's a trend, however, that makes a difference. And again, that creatinine level is, as I said, sort of dependent on your muscle mass. So if you're the doctor needs to sort of keep that in mind. If you're, God forbid, a cancer victim and you've had a significant amount of muscle wasting as part of the result of the cancer, and your creatinine has gone from 1.2 to 1, that change may actually not be low enough if you lost a lot of muscle mass. So you really have to think about, like, the doctor really needs to think about you as a patient more than worrying solely about whether the lab company has put an asterisk or an L or an H next to the lab result.
Thank you. A couple more questions from online. What are the long-term side effects of ACE inhibitors, and how does this affect treatment of kids?
Oh, that's a sort of a two-part question. ACE inhibitors have been around now since the mid-1980s, and there are certain things we know about them that are critical to women of childbearing age, because it turns out that they can cause birth defects if the women are taking them early in a pregnancy, and taken late in a pregnancy. ACE inhibitors and their cousins, the angiotensin receptor blockers, or ARBs, they have the same side effects, can actually cause acute kidney failure in the babies. So there are certainly effects for women of childbearing age that have to be paid attention to. What we know in adults over now 30 some odd years of experience with ACE inhibitors is that they are remarkably safe if you can tolerate them. They don't appear to be long-term side effects. The short-term side effects that most people run into is the fact that many adults and far fewer children cough, and there's a sort of idiosyncratic reaction that some people have, but it means you can't take ACE inhibitors, and that's that you can get swelling of your lips and tongue. And that's much more common, relatively speaking, it's still pretty rare, with ACE inhibitors than it is with ARBs. But long-term, these drugs seem to be fairly safe, and as a consequence, pediatric kidney specialists feel pretty comfortable using them even in infants, at least once they're about 40 weeks or 44 weeks of gestation or equivalent. But I can't tell you with certainty. There have not been very many pediatric long-term studies of ACE inhibitors, but there haven't been many reports that they've been problematic either.
And just as a note, Dr. Oliver Gross in Germany, I know, is doing a study on pediatric patients and ACE inhibitors, so hopefully we may have more answers as a result of that.
Right.
We have a question online. How often do you recommend lab testing?
Boy, that's a really fascinating question. So I'm an old person, relatively speaking, and I have trouble convincing my internist, who's very evidence-based, to do my personal blood work more than every other year. And even then, some of that's done because I actually take a statin, and that's the only, knock on wood, it's the only medicine I'm on. So if you're healthy and you don't have a family history of kidney disease or anything else, routine screening is really based best on evidence. The problem with evidence is interpreting that, and this sounds odd, but I actually rely on my primary care provider to synthesize the best evidence for me in terms of how frequently I order blood tests. If you have kidney disease and it's stage 1, I would be doing blood tests at a minimum of every year. The worse your kidney disease, the lower your GFR, the more frequently you're going to need blood tests. So if you have CKD stage 3, it's probably going to be quarterly. But so much of this is individualized.
Thank you. We have someone who raised their hand online. Autumn, if you'd like to ask your question.
Yeah, so my family, we come from the X-linked Alport Syndrome, and so my dad had it, so I have it. And I've got 2 little boys now. One is 2, and one is just a couple months old. I'm just wondering, at what point should I start having them tested for, their GFR, or because there's, 50-50 chance that they won't get it from what I've been told. I don't know if you have any advice for that.
It's always individualized, and without having a conversation with you and seeing your children, it's a little bit difficult. But generically, again, it has to do with the fact I'm not a big fan of drawing blood on people who don't necessarily need to have blood drawn. The simplest thing to do for affected male offspring is to do a urinalysis, and most children by the age of 2 or 3, if they've got Alport, will already have some blood in their urine. They may not have protein in the urine, but they'll already have some blood in their urine. And if they do, then you really want to make sure they've had their blood pressure checked, and you might want to get baseline blood work. And the key also then, if you're young, is whether or not you have protein in your urine. So the urinalysis will look for both blood and protein. As far as infant screening, I don't know. We might. It would depend on the circumstance. I might try to go to the effort of collecting a urine by putting one of those urine bags on and seeing if you could collect the urine. But not having blood in the urine at this age, for me, wouldn't be an absolute guarantee that there isn't a risk for Alport. It's not cheap to do the genetic testing. It's really not cheap or easy to do a kidney biopsy. And actually newborns have narrow, thin basement membranes normally anyway, so it's really hard to make the diagnosis. And blood work would be totally normal in an infant. So I would typically wait until children are sort of toilet trained and it's easy to get the urine as the first time I'd screen.
Okay, so just kind of waiting until if there's any blood in the urine, then maybe consider seeing a nephrologist, but until then, just kind of wait for symptoms kind of thing?
Right, and the blood would be microscopic blood. It's not something you would see.
Yeah, exactly. Okay.
Right.
Thank you. Are there any other questions, either online or on the phone? Please feel free to jump in and ask. All right. Well, if anyone on the phone or anyone who is watching this presentation online after the presentation is done, if you have any further questions, you can share them at info@alportsyndrome.org. Again, it's info @alportsyndrome.org, and we will make sure that your question is answered. Oh, we do have one more question. At what point do you recommend treatment for kids?
That's such an incredibly varied answer. It's very, very patient specific. The easiest generic answer to that is I'll absolutely treat, and we even have to be careful with what we talk about treatment. Right now, there are a number of clinical trials that are crucial that are going to change what I say, and so in 3 years what I'm saying right now will be absolutely outdated. But right now, the only treatment we have are things like ACE inhibitors, which delay progression. And for me, I don't necessarily think about starting an ACE inhibitor unless there's microalbuminuria or proteinuria or high blood pressure. And I've taken care of some children with Alports, certainly girls, it's definitely different, but with boys who've made it into the second decade of life with no real reason for me to initiate therapy. And I feel a little uncomfortable with that, but part of what you do when you initiate a therapy is to hope you can measure an endpoint. So the thing about initiating an endpoint then is you want to say, well, there's protein in the urine. Can I see that the protein in the urine is coming down when I started this ACE inhibitor? Or it didn't come down much, but it came down some. Should I increase the dose? So initially what you want to do is sort of think about, when I start a therapy, can I measure whether it's having an impact? And I'm reminded by a wise soul that I also should mention, and she's absolutely correct, that there are in fact Alport Syndrome treatment guidelines which are available on the Alport Syndrome Foundation website that will also help guide when to initiate therapy.
Great, thank you. When do casts in the urine, what do casts in the urine indicate?
So, yeah, very good question. You may notice that I didn't describe casts at all. Casts are things, in this case, that literally come out in the shape of the tubule that the cast was formed in. The British, of course, have a much better term for them. They call them cylinders, and because they look like cylinders. And there's different things that can be in casts. In Alport syndrome, because there's blood in the urine, there can be red blood cell casts. There are casts that appear literally in the shape of the tubules where the red cells sort of clump together before they get passed through. It reminds me of those Drano commercials where there's a plug in the U trap of a sink, and you watch the Drano push that plug through. The casts sort of come out the same way, only without hair. The thing about casts is that you need to look at the urine under a microscope, and increasingly fewer and fewer places do that, unfortunately. And the other thing about that is casts break down over time. So unless somebody looks at a reasonably fresh urine and spins it a little bit gently in a centrifuge and looks at it, it's very hard to see the casts. So if you've got somebody who's got blood in the urine and you see red cell casts, that's a pretty good marker that there's something wrong with the glomerulus, with the filtering unit. But if there's blood in the urine and the urine sat around for a while and then the lab says, well, we didn't see casts, I don't know what to make of that. And if the doctor doesn't spin it and look at it sort of right away under a microscope, him or herself, I don't know what to make of it. So the presence of casts is important if you do the test right, but the absence of casts doesn't help me most of the time. Even, frankly, when I look at a fresh urine, the casts aren't always there.
Thank you. Are there any other questions, either online or if anybody would like to jump in on the phone and ask a question, you're welcome to do so. If not, again, the email address is info@alportsyndrome.org, and you are welcome anytime to ask any questions about this presentation or anything about syndrome. Thank you so much to Dr. Morgenstern. This has been incredibly helpful. I know that all of the people on the phone and the many people who are unable to attend live who will view this later are so grateful for your time and really appreciate the information that you provided today. So thank you.
Well, thank you. It's my pleasure.
Thanks, Dr. Morgenstern.
Mm-hmm.
Thank you. And once again, I want to say thank you to Global Genes and Reata Pharmaceuticals for the funding to make this presentation possible. That will conclude our program. Again, info@alportsyndrome.org if you have any further questions. Thank you all.